Go.
All right, this is Leonard Kish with HIBC TV. We are at the Engage conference in Washington, D.C. as part of Health Innovation Week. It's one of the first conferences on patient engagement, which we all know has become a very hot topic in the age of value-based medicine, or at least the beginning, we hope, of the age of value-based medicine. And here with a panel of patients. We have Sarah Kucharski on my left, Elisa Hughley on my right, and Greg Masters. So let me ask you first, Sarah, what do you think of the conference so far?
So far I've been enjoying the conference. It's been a little bit interesting to see the emphasis on industry and government forces rather than necessarily the patient voice. I think we're just now really getting to the point that we're including that. And keeping the patient voice at the center of the discussion is such an integral part to getting across the importance of patient engagement and what it really means and the human relationships behind it, so that it's not something that people are simply paying lip service to as a marketing ploy to bring in patients.
Right. Do you think there's a bit of, it's part of meaningful use? So it seems like there's two dynamics going on. There's meaningful use, which is pushing incentives around technology, but then on the other side you have value-based care. Do you think that, and there's quality measures associated with that value-based care with Medicare and Medicaid. Do you get the sense that there's real things happening, or is it more kind of a check the box, we're doing this, that, and the other kind of a mentality?
A little bit of both. There are those who get it on an intrinsic emotional level. And I think those are the ones who are really pushing the applications to make sure that things are happening to improve the patient experience. And then on the other side, there are those who are simply following the mandates and checking boxes because it is what they've been told to do, and they'll be penalized if they do otherwise, which the penalties aren't exactly what patients care about.
Right.
Patients, to them, meaningful use has an entirely different definition.
Right. You mentioned emotion. Do you think emotion is can you do patient engagement without emotion?
I'm sure you could. I don't think you should. To engage with someone means to participate in a dialogue. And there has to be a give and take. There has to be an openness. And if you just want to go through the motions of that and mimic the interactions, then the dialogue's not going to be as rich.
And Elisa, tell me about your experience at the conference. What have been the highs, and there have been any lows? What's been disappointed?
Well, you always start with the positives.
Yeah.
So I think it is a nice cross-section of the necessary players. I think MedCity has worked hard to try to get the important stakeholders to the table, and it's been a good featuring of patients, perhaps getting the patients out first so that to contextualize the discussion. I really liked when you led your panel because you put everything in a context and a perspective. I feel like we're in the stage where the toe is in the water on engagement, and a lot of people, a lot of entities that are talking enthusiastically about it, it's still very abstract, and that's why you have to go ahead and do the face, contextualize it within the story, so that once we start getting to the policy and the more abstract things, it means something. I was disappointed that the one talk addressing community engagement was 10 minutes at the very end of the first day before our happy hour, when people are least likely to focus. And I really think Dr. Freeman, because of his tenure, could have, well, he did, but I don't know that we had the opportunity to really embrace the impact that whole lineage that he gave, and then go back and rejoice at the revisiting of the navigation system of the Navigators, because when you talk about patients, then the other side of that is patients in the collective community. So, of course, as a public health professional, I always have to bring in that piece. And I don't think it's, I think the public health professionals need to be more willing to come to the table too. I think they still don't realize that this space exists. So you have to work on that.
To give, it's Dr. Freeman, right?
Mm-hmm.
To give the sense of community its due, what do you think are the takeaway lessons that we can apply in other areas of healthcare from what he's learned?
Well, first and foremost, and the idea of the patient navigator is just another way to accomplish that caregiver role. In the last panel, we had a caregiver, and true, most of the time it is a family member, but there was power in recognizing that individuals don't necessarily have that, social determinants of health. You may not have that support system of an individual just to sit there and hear the things that you don't hear. Remember your medicine. Have the questions for you. Certainly within my family, my mother had, 7 other brothers and sisters, 4 of whom have already passed away at this point to cancer and lost to cancer. And it's been a succession of, at the time, being there. So we did have one uncle who opted for no care at all, which is great too. But by doing this, creating these patient navigators, you are bringing someone who's from the community, but also has the skills to literally translate. And then, of course, in the Latino community, literally translate.
Right.
But having a person to interface that is trustworthy, but that can also, because we all have the title, advocate, and then crosswalk in terms of these are the instructions, well, what's going to keep you from getting that done?
Right. The idea of language and translation has been brought up many times, that patients don't go, or they go to the doctor's office, they don't really understand sometimes a lot of what's being said, and they don't remember afterwards, and so that even though there might be a really good interaction, even when the engagement face-to-face is good, the understanding and the support structure required to either prep the patients or the physicians ahead of time before the appointment, during the appointment, after the appointment, to make the most use of that limited resource of physician time is really key.
Definitely.
How about you, Greg? What are your big takeaways from the MC Engage conference?
Well, I've been somewhat constrained because I've been here.
You did do a panel.
Mostly filming, but yes, I got to participate in a panel on patient engagement in the ACO world, and my takeaway perhaps is some of the comments that circle back in that through my colleague Pat Salber, I heard that there was some buzz after the session that, well, that was kind of paternalistic, versus truly patient-centric, that it's still, and what I was trying to do on the panel was I was trying to get to, I started with the idea that there's no standard definition of what patient engagement is. There was a survey that NEHIC did, and that, so the question was, how did you put the conversation in front of your stakeholders, hospital, health system, medical group, what have you, Athena, which is a vendor, and gain context and perspective and a framing, if you will, what is patient engagement? And how do you implement it? What are the tools? What are the apps, tools that you're using? So, I went at it, well, the cultural shift. How are you enabling conversation around the cultural shift to go patient-centric and not have it be just rhetorical? And even with that, I still heard the comment that it sounded pretty paternalistic.
Right.
Well, again, I think you did a great job of setting the context, and it's good to have different disciplines represented, but in terms of what engagement is as a strategy, I only heard one group describe an engagement process. As
Right.
someone myself who serves on 2 community outreach councils, you know, that at least is the beginning. Now, of course, in the 21st century, when you finally went back after all the technology to the social media piece, which is that new extension, the open forum town hall in 2.0 world, we went back to the the hospital paradigm of faxing and just not, just not there yet.
Yeah. Bring up a couple other interesting words. I always lock in on some words. One is culture. There's been which I'm excited and impressed to see as part of this conference and event. There has seemed to be a lot of focus on culture change and the need for that. Will, you brought it up talking about littering, how in the 60s and 70s, there was, people would just throw trash out the window, but there was big public service and through a lot of effort, a lot of advertising, things changed. And I'll phrase the question this way. For littering, there wasn't a anti-littering group. But in some respects, I think there's a lot of anti-health messages out there that we're constantly inundated with. What can we do to...
Do you mean in the form of commercial messages?
Yeah, commercial messages.
Lobbying, is that how you phrased it in the
Lobbying,
tweet?
yeah, exactly. What can we, if we're going to go out on this path towards making health and engagement a cultural shift, what can we do? Are we going to wind up in conflict with a lot of vested interests?
Conflict can be good, though.
Right.
Conflict, if you've got conflict, then theoretically you've got people who care enough about the issues to have an opinion and to express that. And I don't think any one of us on any side could say we are absolutely 100% right all the time. And it's, again, being open to dialogue so that we can take the different viewpoints and take that conflict and take the high points from it and assemble something that may be what we haven't even envisioned yet, so that that's something that really solves our health issues in the future. Yeah, I hope for conflict. Conflict is good.
What about the idea of culture and cultural change? What's it going to take to get us on that path, Lisa?
Well, thanks policy, that's helping. Actually, I was saying during lunch to some individuals that I was talking to that, particularly in healthcare, you don't do anything until you absolutely have to. And so policy is now saying you have to. So that's the start. And of course, we're seeing, you're the expert. We thought the whole timeline on high tech was going to be very different than it is. It's, people lobby, deadlines get pushed back.
Right.
But I'm very hopeful because I feel like we are on the right path. And just having the new lexicon of language, even the right word being said, we might have to define some terms or get on the same page of what a term means, but certainly I'm hearing in this space stuff that I only heard in grad school and, in that other space. So in the collection of a lot of different players that I never would have expected to hear talking about these things, that makes me encouraged.
Yeah, and for me, I'm impressed in this conference that there's been so much talk about behavior change, about behavior. Now, it's not just a new app or some new tool, which, at HIMSS or some other conferences, you get, or especially others that are more technology focused, you see technology as the answer, but it seems that there's a recognition among a lot of the providers and even some of the app developers that are here that there's a real focus on behavior, behavioral economics, behavioral science, and behavior change. is that going to become one of the required skill sets for providers in the future? I mean, is everybody going to become a behavioral scientist in healthcare now? Greg?
Good question. You know, I mean, considering the devaluing and the discounting of the behavioral sciences, it's not real science, it's the behavioral.
Well, now that it has economics behind it, which is
Well-
also not a real science, but the two of them together
It's
almost
just
sound like a
social.
science,
It's
right?
just social.
Yes,
It's
just-
just
it's
social.
Isn't that where we live?
Yes.
We live in just social.
Unfortunately.
But, well, is it unfortunate, or is it just, there's just really a lag to kind of,
Yes.
because it's what's real and what matters.
Mhm.
And if this is, and if the technology and the consciousness is all about moving it towards be where your customer, be where your stakeholder, be where whomever is at, that's not just about being in the space, but that's being present and in an authentic relationship with them.
Absolutely, and I think what you're describing is moving from where we remove the word just.
Right.
You know,
Thank you. Yeah.
Because yes, it's social, health is social, in addition to being personal, you know.
Yeah, the problem with it's social, the word, and social media, social science, is it has this other connotation. It's interactions, but it's also a social occasion. It's not serious. It's not business. You don't get business done by social media, right?
But it's unlocking through neuroscience. It's unlocking through a number of ways. But you know, when you would, I'm going back to pre-grad school, just undergraduate, sociology. So what's your major? Sociology. Sociology.
That's a good
Oh,
one.
is that like PE? You know, I mean,
Right.
so you know, we've made monumental strides.
Well-
And my answer to your question is, you know, we're not there. The signs are positive, but the jury's out.
Well, and I think if we're going to have any conversation about behavior, then we have to mention BJ Fogg.
Yeah, I agree.
And BJ
Big
Fogg
fan.
with his great model of the behavior equals motivation, aptitude, and trigger. And this curved relationship of if the motivation to do something isn't very high, that it needs to be
Mhm.
incredibly easy to do.
Right.
And if something is made easier to do, then the motivation doesn't have to be very high. And it's not rocket science, but it's so incredibly useful and so incredibly applicable to absolutely every interaction that we're going to have. And so if we're expecting people to engage with patients,
Mhm.
and maybe their motivation isn't high other than penalties and possible fees and occurrences, how can we make it easier? And what can patients do? What part can patients play in making it easier and or raising motivation for them to do so?
Right.
We had a panel on that health literacy, I thought was helpful. I thought that was good too. And it was balanced, so it's what we can do as patients as well as what the providers, caregivers.
Yeah, it seems to be among a lot of providers, I don't know if it's, a myth is the right word, but it's one of those mythical stories that patients don't care enough a lot of times, right? That left to their own devices, you know, they need help, they need structure, all these kinds of kind of paternalistic
Very
things that you say, right? But I think it's great, and with my own experience as a patient last fall, I wound up writing a piece about that, and I think you're right. Actually, the motivation, I think we spent a lot of time giving physicians the tools, right?
Right.
But they have you know, in the Fogg behavior model, it seems like there's a lot of risk and very little reward for sharing information and these things. But patients, when you become one, you have all the motivation in the world to get the tools and to use them effectively. So to impact change, it's good to see, I think, the tide turning towards giving patients more tools and more information.
Regarding provider risk, there's nothing to be gained if you're not willing to risk anything. And I know as a patient, I want my doctor to be happy, to be healthy, to be well compensated, to be in an environment that allows that provider to be at his or her highest and best use, so that he can provide me the best care. And it's in my interest to do what I can to make their experience better, so that in turn they make mine.
So I think we need to wrap
Yeah.
up, but hey, I want to thank Chris Sepper, Med City News, Med City Media for putting on this conference. It's fabulous to see the representation of those of us in the e-patient community here. And I have to say, this is a first. Our beloved Regina Holiday is behind the camera.
Give us a cameo, Regina.
Yeah, so maybe we could, sorry to preempt the monitor.
Oh, no, you're the pro.
We're
Just filling in.
We have our next, but why don't we just go down with just sort of wrap-up thoughts about the conference, start with you.
I'm excited to see how the rest of the conference goes. There are a few sessions at the very end of today that I am definitely looking forward to. We'll see what kind of dialogue comes out of that.
I just want to say, remember, at the heart of engagement is caring and listening. It is an exchange.
And I just, I'm happy to be here. And my e-patient narrative is one I'm still trying to get my hands around, and it's still very difficult today to articulate. I made an attempt at it a while back in a blog post, but it's still a discovery process. And mine is in the mental health domain, so there's a lot of shame associated with it, and I'm recovering from that a day at a time.
All right, well, thank you. This has been Leonard Kish with Sarah and Elisa and Greg from the Engage Conference in Washington, D.C. Thank you.
That was great.
That was fantastic.
Yay!
I unfortunately couldn't